understand.
Mm.
Ah.
Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We appreciate your taking the time to join us, and we trust that you will have an opportunity to listen and participate in a very vigorous discussion. Without further ado, I pass it over to our founder, Dr. Randall Maxey.
Thank you very much, Dr. Barbara Davis Stevens, and welcome to our listening audience. And our topic today has to do with what's going on with these weight loss drugs. But there's been so much confusion put out of the Washington, D.C. area where Dr. Walker's in charge. And he's got a friend named Robert Kennedy Jr. who's been putting all sorts of misdirection and information that makes us not really know what to expect out of the federal government. So just a statement I wanted to make. And put up the slides if you would, Simon, please. And I call these current problems and issues that we're not very trusting in what's coming out of the Department of HHS and Human Services. Go to the next slide. And we know that they're eroding trust. And what erodes trust in the federal health officials is they're acting without transparency. They're making alterations and recommendations in the absence of any supportive data. We know that they should have rigorous scientific and policy processes conducted by trained professionals, and they need to follow recommendations from medical societies, from the groups like the American Academy of Infectious Diseases, the American Academy of Pediatrics, American Academy of uh, Obstetricians and Gynecologists. And we need to have some unity on looking at peer-reviewed information, not just something coming off the top of somebody's head. So let's go to the next slide. We want to have essential vaccines that are recommended for African Americans. And as in everything we do, we say that you should check with your physician, your provider that you have faith in for the details. So we know that vaccines do, go to the next slide, Simon, please. We know that vaccines prevent serious illness. They prevent hospitalizations and disability and death. We know that Black adults often have lower uptake, meaning they don't take as many of the vaccines they need to have, especially the flu, COVID-19, but they have higher amounts of hospitalization rates from respiratory infections. We know that many of our adults also have conditions such as heart disease, kidney disease, diabetes that raise their risk. So they need to have up-to-date vaccines according to what their healthcare provider advises them. Let's go to the next slide. If you can make those a little bit larger for me, if you can. Is that possible? That's Neighbor Stevens. Do you want to help read this one?
Okay. So we're going to talk about some of the core adult vaccines. Influenza. We see a recommended vaccine come out every year for people 6 months and older. COVID-19, current seasonal vaccine for everyone over 6 months. Let me stop there and say these have been the recommendations for years up until very recently. Pneumococcal, single PCV dose for all adults 50 and older, or those who have risk 19 to 49. And that's particularly important in our community because um, our um, community has to deal with sickle cell disease, and this is a very important vaccine for those who have sickle cell disease. Shingles, which has a combined vaccine, RZV Shingrix, 2 doses for adults 50 and older, also for immunocompromised individuals 19 and older. Now, shingles. What is shingles? Shingles is the reoccurrence of a herpes zoster virus that, for those of us uh, less than, I would say, 60, probably have not had the exposure since they had the opportunity to have chickenpox vaccine. But those of us who in my age group, there was no chickenpox vaccine. We all had chickenpox. And that virus stays with you and it comes back and presents itself in a very painful disease called shingles. Hepatitis B, there's a vaccine universal for ages 19 to 59 and advised based on risk for those 60 and over. Why is hepatitis B such a valuable vaccine? Hepatitis B used to be a very common disease. The introduction of hepatitis B vaccine helped to lower the incidence. It's not eradicated, and therefore vaccine is still necessary. Tdap or tetanus, for those who are adults, it's recommended that they get a booster shot every 10 years and with each pregnancy. So why do you need tetanus? And the little d stands for diphtheria. The reason that you need tetanus is for when you might have that unexpected accident, cutting your fingers, stabbing yourself with a tack or a nail, or any kind of injury that can introduce, that breaks the skin barrier and can introduce the tetanus bacterium into the system. HPV, there's a very interesting commercial that at least plays down here in Nashville for HPV, is recommended for those through age 26, beginning in adolescence, actually 12, through age 26. Fairly, time flies fast. A few years ago now, the recommendation was revised. And so individuals 27 to 45 need to have the conversation with their provider as to whether or not their sexual activity makes it a good idea to get HPV. Now, why do we want HPV? The HPV virus is linked to the development of cervical cancer. And by having the vaccine, you can lower an individual's risk of having cervical cancer. RSV. RSV, respiratory syncytial virus, is well known to all pediatricians. The young, small babies who have immature lungs are particularly vulnerable to a very severe expression of this respiratory infection. We now have a recommendation for all adults 75 and all adults who are over 75 or older. And the reason for that, and the ages 50 to 74, again, if they are at increased risk or have comorbid conditions that can make the disease very serious. It destroys the air sacs in the lungs. And so if you've got underlying lung disease like asthma, COPD, RSV, it's very difficult illness. And that's why that recommendation is there. MMR, measles, mumps, rubella, varicella is the proper name for chickenpox. That is recommended for adults if they are not immune. Hepatitis A is recommended, especially with certain areas of travel. And meningococcal disease vaccine is recommended for young adults, college-age kids, and older who are in um, congregate housing, like dormitories. Because although it's not that common, once you're in a environment where, fairly close proximity, you're at an increased risk and it causes meningitis. So we certainly don't want that to happen.
And going back to hepatitis B, for people who are around any kind of bodily fluids or blood that are caretakers of older people, anybody, that hepatitis B is very important for you. Thank you, Dr. Neighbor-Stevens. So one of the things we want to do is take steps to make sure that you have a vaccine appointment with your clinician or pharmacist. Make sure you bring your immunization records and ask specifically about the pneumonia, the RSV, and all the things that she's talked about. And especially if you have diabetes, heart disease, lung disease, etc., you might qualify to have a vaccine earlier and they'll pay for it. So be sure that everybody in your family is appropriately advised. So let's just show the next slide because it's got some of the references. And then I want to get to our topic for today.
Before we get to the topic of the day, I think there's something we should address on this topic of vaccines, which is access. Besides recommendations that are counter to existing clinical data, we also have to have a conversation about the obstacles to access that are being thrown up in various parts of the country. Uh, while we were under the COVID emergency, if you recall, we could go to the drugstores and get immunizations without a doctor's prescription. Some states have now adopted the position that in order to get vaccines, even if they're recommended, the few that are still recommended, you have to have a physician's prescription. So that varies state to state. You need to find out where you live, what the current uh, requirements are, so that you won't have a surprise when you get to the drugstore.
What's the worst state?
Well, now, for what I'm talking about, if you're talking about Florida, that's not the issue. In Florida, they just said there's no mandatory vaccine, period. But and I've read the number, it's a lot of states that have thrown that barrier of requiring the prescription. I'm sorry, I can't remember the states.
Okay.
So let me just add from a psychological perspective, in addition to the fact that the vaccine recommendations are changing, and the fact that in Florida in particular, the governor and the state surgeon general have decided to remove any requirements for any vaccines when children are put in school. There's something else that's going on there. And I was especially upset, is the only polite word I can use, to see the African American Surgeon General of the state of Florida say that vaccine mandates should not happen because who is he to tell someone what they should put in their body, and that vaccine mandates are like slavery. And I never thought I would hear a black, I can't even say it. I never thought I would hear a black physician compare vaccines to slavery. It shocked me, and I think that it's part of what we're seeing now, where folks are trying to use all sorts of additional tactics to get folks to not do what science has been saying, this is a good idea. Well, I don't care what science says. If I tell you to do it, it's like slavery. It's unconscionable that someone who looks like me would go to that length. But welcome to America 2025.
I wonder if we can send him to El Salvador.
Well, I'll leave it at that. I don't know where I want to send him. I just want our community, our larger community, not just the Black community, but our community to recognize the fact that when children are not immunized, you see the illnesses impacting other children. And we've seen these measles outbreaks. We will continue to see outbreaks and children impacted by just foolishness like this. When you intimidate or fearmonger a whole community by comparing mandatory vaccinations to slavery, it's just wrong. So
You're right. Thank you very much. Did Dr. Lawson join us yet?
he has.
Okay, very good. So I'm going to talk about GLP-1 receptor agonists for weight loss, the benefits and the risks. What is the real story? What is the whole story about these weight loss drugs? So let's define what they are. Examples of these drugs are semaglutides such as Ozempic, everybody's heard about, Wegovy, tirzepatide, which is Mounjaro and Zepbound. They were originally developed for type 2 diabetes, but they're now widely used for obesity, cardiovascular risk reduction, and they're mostly very good. Let's go to the next slide. Go to the next slide. So they have a mechanism of action where they act like what is called a glucagon-like peptide. So just say GLP. And they increase the amount of insulin. They decrease the amount of glucagon. And what is glucagon? That is a hormone that's produced by the pancreas, but it makes more glucose available when it happens. But mainly it also slowly slows down gastric emptying, so you feel fuller. So they call it satiety. It reduces your appetite. Next slide. So on this slide, which is so small I can barely see it, but it tells you that they work on the brain for appetite suppression. They come from the pancreas. They increase insulin secretion and decreases glucagon secretion, and acts on the stomach to slow down the emptying process of food so you feel fuller longer. Next slide. So, Dr. Walsh, you want to take this one?
Sure. With respect to those drugs, let's look at some of the weight loss results. So, semaglutide, approximately a 14% mean loss. And this is from a New England Journal of Medicine article in 2021. Tirzepatide, approximately 20% mean weight loss from the Journal of the American Medical Association in 2023. And some patients have greater than a 20 to 25% body weight loss.
And take
That's a
the
lot
next
of weight.
slide.
Next slide. So comparison of the weight loss using these drugs at approximately 72 weeks. I think that would be 72 weeks of use. And then the percent of mean weight loss. So with the Wegovy, you're somewhere around, I guess that's 13 and a half, 14%. With the Zepbound, you're about 20% of your weight, your mean body weight that you can lose. And then with making lifestyle changes, and I'm going to assume that's lifestyle and diet, you're going to be less than 7.5%. of mean weight loss. Something just popped up. There's someone that can't see the slides. I can see them. Um, can you see them, Dr. Maxey, Dr. Neighbor Stevens? Okay, Dr. Lawson is saying yes. So
Yes, I can see them.
I can
so
see
the
them.
slides are being put up. So I think it may be a local computer issue if you can't see them. I'm sorry.
Okay, let's go to the
Next
next
slide.
slide.
You want to go ahead, Dr. Maxey?
Yeah.
Are you
So
gonna go
somebody
ahead?
said it decreases cardiovascular events and sometimes as much as 20%. Wegovy has a thing where it actually decreases heart failure hospitalizations, and Zepbound decreases hospital admissions secondary to heart failure as well, and that's reported in the Lancet. They improve ejection fraction modestly. Next slide.
Uh, Before you go on, Dr. Maxey, just a little moment to say that ejection fraction means how much when your heart is squeezing to push the blood out to the body, you want a high ejection fraction because you want that blood to get out and go where it's supposed to go, right?
All right. So if your ejection fraction is above 60%, you're okay. If it gets below 60%, you're in trouble.
You know, you just got in trouble just now. You had a psychiatrist trying to give cardiovascular advice. That we don't want that.
But you had a cardiology going through there someplace. You want to take this one, Dr. Walks?
Okay. Effect of GLP-1s on cardiac function. Let me sit with my cardiologist hat on for a minute. Don't tell Dr. Williams. Um, so we're looking at the ejection fraction and the change of the ejection fraction over the course of 12 months. And we can see from the line that's going higher, going from 0 to 12 months, that's the line when you have the GLP one therapy. So cardiac ejection fraction is increasing. That's great. When you don't have the GLP ones, when you're just using a placebo, you can see that over time the ejection fraction actually decreases. So the blue line shows people's hearts pumping better, getting better perfusion, and the tan colored line shows that the functioning of the heart is actually getting worse over time. So,
Okay.
next slide, please.
Dr. Lawson, you and Dr. Walks are going to help me with these next few slides. We're going to talk about the neurocognitive risks and benefits of GLP drugs. So go to the next slide. It starts with neurocognitive protection, Dr. Lawson. Or Dr. Walks?
Dr. Lawson has to. There he goes. You're
There's a
unmuted now.
decreased risk of Alzheimer's and dementia. And this, by the way, is very consistent with recent data showing that the such disorders as diabetes, hypertension, and so forth actually increase the risk for Alzheimer's and dementia. The mechanism is decreased inflammation, increased brain insulin sensitivity, and there are ongoing trials now for Parkinson's and memory protection as well. I wouldn't be surprised if we show some benefits for Parkinson's.
Can you speak a minute about that brain insulin? How does that affect things?
Well, what we know is that the neurons, frankly, are benefited when insulin is there because it increases glucose input in terms of the neuron itself, so it functions more effectively. And we also know in diabetes and related issues that high glucose levels outside of the neuron results in disorders such as neuropathy. So, to the relationship between glucose, insulin, and nerve function is well demonstrated. So this really shouldn't be surprising. And the other thing, of course, is these are anti-inflammatory agents, which should reduce the level of amyloid plaque formation, although that's still a controversial discussion.
Okay. And if you take the next one, I want you and Dr. Walsh to be the hitters on these next few slides. Take the next one, Dr.
Yeah,
Walsh.
that okay. GLP-1 drug goes right to the brain receptors and it reduces appetite, increases satiety. And the other interesting thing is not only is there improvement in cognition, but also mood. Well demonstrated that that diabetes and other disorders have an increased risk for depression and related disorders. And I just want to throw in another point that I was going to make later, but I'll make it now. And that is that we keep calling these drugs weight loss medications. If you sit on your ass and eat like crazy,
Oh,
you will be unlikely to lose weight.
Yeah.
I've examined most of these trials, and every one of them requires that the participants exercise and eat less. Every one of the clinical trials.
Okay.
The trial in which the person sits on his butt and does not eat, that study I think has been demonstrated well enough in the real world to know that it doesn't work.
Can you speak a minute about what is cognition exactly?
Cognition is brain function, is the ability to use the brain to think and to have thought. So we distinguish between cognition, which is how you process information, versus mood, which is how you feel about things.
Thank you. Dr. Walsh, you mind taking the next several slides?
okay. Reported cognitive risks, brain fog and mild memory issues, um, often transient, more common early in treatment. I see a couple of kidneys up there, and then possible links to hypoglycemia with insulin or sulfonylurea use. So these are some of the risks with the GLP-1 drugs. So while we're talking about them making things better, they can also cause challenges in these areas. Let's go to the next slide. So neurocognitive benefits of GLP-1s. So Alzheimer's risks and dementia risk with no GLP-1s, we can see the relative risk there is higher than when folks are able to use the GLP-1 drugs. So this is a slide that gives a visual picture of what we were talking about over the previous couple of slides. Next slide, please. Neurocognitive risks versus benefits of GLP-1 drugs. So the risks are in red, the benefits are in green. So we relative evidence strength percent. So essentially, we may have some risk of brain fog, some negative risk for mood changes, and some negative risk of nutrient deficit, but we are going to have more of a chance of having dementia protection and more of a chance of having vascular health with the GLP-1 drug. So if you're looking at should I risk maybe getting the brain fog or mood changes or having a nutrient deficit versus getting some protection from dementia? And all the slides earlier talked about significant decrease in hospitalization from heart failure and significant difference between improved ejection fraction or heart pumping and overall vascular health. This is why we put these things on Black Health Trust and we say talk with your practitioner, talk with your doctor, have a general primary care practitioner that takes care of you, because these are all things that should be discussed when you're looking at, well, should I start Wegovy or one of these other drugs?
So Dr.
Uh,
Walk, I had
yes,
a
sir.
personal experience that inspired these slides. My wife told me I wasn't eating enough, and I had been taking Ozempic, and turns out that I wasn't getting enough protein,
Mm,
and I was losing muscle mass. I'm exercising, I'm doing everything, but I wasn't eating properly. I wasn't taking vitamins. So there are a lot of things you have to do, even if you're a physician, to do it right. Not just take the drug, not just exercise, but you have to look at the whole picture of what these drugs do and what you should and shouldn't do. So thank you very much for that.
No, and let me just follow up with that, Dr. Maxey. This is why it's so important that whether it's Dr. Lawson, Dr. Neighbor Stevens, Dr. Maxey, Dr. Walks, Dr. Hines, whoever it is, we talk a lot about what the information shows and what the science shows, and we talk an awful lot about talking with your practitioner, with your pharmacist, because it's really important to go back to Dr. Lawson's very accurate description of how not to sit on your whatever we describe it and expect everything to work like magic. You've got to get off of your whatever you're sitting on and understand how you have to eat, understand how you have to move. This is like it's like watching exercise on TV and not doing it. You've got to really participate in all of the dietary and all of the activity things that are a part of this. We none of us can really say that enough. You can't just be an inactive participant and just take a pill and expect things will get better. Life doesn't work that way.
Let me
Next
also add
slide,
one more
please.
thing, Dr. Max. That is that, as far as I know, and maybe some folks have some additional data, there's been no demonstration that agents cause persistent cognitive deficits, that the effects generally tend to be transient. On the other hand, there's good evidence that these agents, protective effects in terms of Alzheimer's and other, these are long-term benefits that will
Hmm.
continue for the rest of the person's life.
Hey, you want to take the next two slides, sir? That's Lawson.
Neuroprotective potential. One is improved brain insulin sensitivity, reduce neuroinflammation, and also protect against amyloid beta and tau pathology. And as I mentioned before, amyloid beta and tau is believed to be the underlying basis for Alzheimer's and other kinds of dementia, many other kinds of dementias. And I might also mention there's a lot of emphasis now on um, doing what we can in terms of neuroprotective properties in terms of medications, both not only in psychiatry, but neurology and other fields. So we're not just looking at brain damage, but we're also seeing if we can find what medications can protect the brain from adverse consequences.
Take the next one too, if you would.
And this is GLP-1 in dementia trials. Placebo is a little yellow line on top, and the GLP-1 drug is the blue one in the bottom. And the key point is the longer you stay in, the better you get in terms of benefits, in terms of cognitive activity.
Okay, next slide. This is yours, Dr. Walks.
Okay. Mood and psychiatric concerns. Reports of depression. And again, we're talking about these particular GLP-1 medications. Reports of depression, anxiety, and rare suicidal ideation. The mood and psychiatric concerns are under review by FDA and EMA from 2023, 2024, and mechanisms may involve serotonin and or dopamine modulation. Um, Again, this is why you talk with your practitioner as you are beginning and continuing to use new medications, or as you add and subtract other medications. There are folks, a lot of folks, who are using diabetes medicines, weight loss medicines, and depression medicines and anxiety medicines. And so it's really important to make sure that your practitioner, your provider, your pharmacist knows all the different medicines that you're taking, and they can help you to address whatever concerns you have and look for whatever is likely or not likely that could pop up.
Dr. Max, I just want to make one other key point. The whole note the term suicidal ideation. This became a big issue in terms of antidepressant medication because the thought was that at one time they were saying that some of these medications may greatly increase the risk for suicide. Suicide ideation and suicide are two different things. Suicide is when you succeed. Suicide, and we find, however, that there are many people who have suicidal thoughts, life's not worth living, and so forth, who really don't do anything about it. And so when we look at these, it's hard to do a placebo-controlled study with suicide for obvious reasons, but also we tend to err on the side of safety. And so when there's someone who says they may have suicidal ideation, we include that as a potential risk. But again, the risk of suicide for these agents has not been demonstrated.
I'm thinking. Once you do the last slide, either you or Dr. Walks. The next one.
Addiction research, GLP-1 pathways affect brain reward circuits. Evidence of, and this is a key one that I discovered almost by accident when I went and drank some wine after using one of these drugs once. There's that reduced alcohol, nicotine, and food cravings. And there's some of us who are using these agents for alcohol treatment. There's also a potential role in opiate and stimulant use disorders, and there are active clinical trials going on at present.
I'm thinking. So pediatricians deal with younger adults, but Dr. Neighbor-Steven, you do this one?
Risk in older adults. Excessive weight loss may cause sarcopenia. Sarcopenia is the loss of muscle tissue. Frailty and falls, which lead to secondary cognitive decline. You know, this is almost which is first, chicken or the egg. And lastly, balance weight loss with protein and vitamin support.
And the next one too, if you would.
Indirect nutritional risk. Well, there's the appetite suppression that was originally noted in the studies when they were looking at it for diabetes. So if you have a decrease in your appetite, one would hope that you would have a reduced intake. And I'd love to hear from someone, if there's someone on who is in the audience that will speak to this, whether just because your appetite is suppressed that you actually do decrease the amount that you eat, or sometimes even if your appetite is not there because eating is causing other gratification, that the eating continues. Risk of micronutrient deficiencies such as B12, thiamine, and iron. And that's because you aren't eating, as Dr. Maxey just explained to us. And deficiencies can impair cognition and nerve function because deficiencies of certain micronutrients are known to cause problems with cognition and decrease in certain nerve function.
Thank you. So there's clinical guidance. I recall that my wife reminded me I wasn't eating enough, but I used to be I could eat 1.5 to 2 plates of dinner. I can only eat a half a plate now. My appetite is much smaller. But we want to ensure adequate protein, calcium. Let's go to the next slide. With clinical guidance.
If you don't mind, I just want to respond to Dr. Neighbor-Steven's point. There's actually been several athletes, and I've had several patients who are what we call emotional eaters. And that is that they kept on high food intake despite being on the medications. They felt awful, but they kept on doing it. Because what was driving them was not the physiological needs for eating or anything else. It was for other issues in different neurotransmitter systems.
And
Okay.
Dr. Lisa from Jamaica has her hand up. Dr. Maxey.
Okay, Dr. Lisa, hello. Dr. Dawes.
Hi. Yeah. I actually use those drugs in my office in for weight loss. If actually before you start them, at least as part of the screening process, you're supposed to screen for depression and anxiety. And actually, if you're going to start them, we tend to treat both. In general, they will just eat less. But if they're really depressed and eating for that reason, usually you'll pick it up in the screening before. But anybody that's being treated in the office usually are put on multivitamins. We put them on a bunch of other things as well, besides exercise, and we follow them. But in general, they will continue to eat less. I've had a couple that I've had to put that I said they really need antidepressants. I've had a few that I added later on, but they were eating less anyway and losing weight.
And so we want to be sure to ensure adequate protein and calcium and vitamin D, monitor mental health and cognition, and encourage exercise as well as social engagement during this process.
You also add creatine. You also give them creatine. It actually does help.
Okay, excellent point. So we know that there are muscle and bone risk also. That was shown in Lancet in 2024. Loss of lean muscle mass can happen, sarcopenia can happen, and bone density loss can happen, and more frailty and falls can happen in people like that. Does Neighbor Stevens, you take this slide?
Muscle and bone risk. I think you just gave it.
Oh, the next one.
Okay, this is a graph showing what happens to muscle mass in the process of normal aging versus what happens when you're on a GLP-1 with rapid weight loss. The yellow line shows what happens with muscle mass loss with normal aging. The blue line is representing what happens with GLP-1s. And as you can see, there is a much more rapid, there is a less amount of muscle mass left. I was trying to say it right. You lose less muscle mass with the GLP-1 use than you do see in normal aging.
Excellent.
No, you lose more muscle mass, right?
Yeah, you lose more, which is why
Yeah.
you have to get them to exercise as
Right.
well. That's why we give them the creatine and why we make them all do weights.
Right.
Okay. So that's why we have the next slide. We have nutritional guidelines.
So back to Dr. Lawson's earlier point. You can't just sit on your whatever. You gotta take your creatine, eat your protein, and get up and move around.
Yeah, what I found is that patients who are depressed and who are on these agents who stop exercising start exercising again. So lose just weight loss in itself encourage people to exercise. But if they don't exercise, you'll lose muscle mass. So the point is that it's confounded about are the people going to maintain a physical regimen that allow them to maintain their muscle mass.
But also we know that as people get older, even though they eat protein, it doesn't metabolize into creating muscle mass as fast as it used to. So that creatine may be a really good idea to look at. So we want to make sure you're eating protein 1 to 1.2 grams per kilogram of weight per day. Taking calcium at least 1,000 to 1,200 milligrams per day. Vitamin D 800 to 1,000 international units per day. And small frequent meals, lean protein, and appropriate amounts of fiber. And there's certain exercise guidelines we talk about all the time. doing aerobic exercise at least 150 minutes a week, resistance 2 to 3 times per week, and resistance is like the rubber bands. It could even be weightlifting, some of that, and flexibility such as yoga and stretching. I tried yoga once; they almost killed me. I guess that was a what's that? Please, what's the thing they do with that machine? Starts with a
Pilates, Dr. Mack?
Pilates. Yeah, I tried that one time. I thought I was gonna die. But stretching is very important. My son does help me stretch. And balance training, as you get older and older,
Yes.
that balance
Yes.
training is very good. And Tai Chi is something that I like very much, and some of the
Yeah.
people should figure.
Yeah.
Dr. Neighbor Stevens, you want to talk about takeaways?
Can I add one more thing? If you're
Yes.
giving, and if you're giving the people calcium, you really should add, and the D3, you really should add K2 to it too.
Say it again.
You should, if you're giving them the calcium and the D3, have them also take K2.
Okay. Excellent. All
When
right.
when I finish with the key takeaways, Dr. Maxey, would you comment on the um, issue that was talked about a lot, especially when these drugs were first introduced? That is the gastric emptying problems, ileus, all of the GI issues.
Yes.
The key takeaways: effective for weight and heart health, need nutrition, exercise, supplements. You need to monitor for side effects, and it's above all else not a magic bullet.
Next slide. There's one more
You
slide.
want to integrate lifestyle changes with the use of the drugs. You want to monitor for frailty, chronic kidney disease, and dizziness or hypotension. You want to add protein, calcium, and vitamin D to your daily intake, and you want to exercise as a part of your overall holistic therapy.
So in answer to your question, there was a lot of problems with a concern about gastric emptying. And for people going to surgery, there were initially some precautions given by the anesthesiologist that you had to modify surgical schedules for abdominal gastric surgery. I think those Dr. Our anesthesiast from Virginia told us those no longer much of a concern with those drugs as we originally thought. So it's not a problem with that. But again, I think nutritional supplementation, the psychiatric involved in monitoring of the patient before, during, and after taking those drugs is all very important, I think. But in general, I think these drugs are good, but you need to look out for the side effects. Again, my wife made me eat right, take vitamins, and I'm back on track again. I have no dizziness, no hypotension. My ejection fraction is pretty good, and I'm not frail. But it's because I eat right on top of it. It's very important. I don't overeat. I do exercise, and I socially engage with at least a few people. Any thoughts? Any questions? We're getting close to the top of the hour, I think.
I have one thought, Dr. Maxey, that we haven't mentioned yet, and it's not really a side effect, it's a result. If you are if you have significant weight loss, especially if you're not a very young person, then you get that flabby skin from where all the weight was lost. And so there are clearly some mental health issues that can come if you're walking around and you have a lot of loose skin from where you've lost a significant amount of weight. I was reading and looking at something about that, and it's a challenge for folks who have to see themselves differently and see themselves as, yeah, you're smaller and you're healthier, but the skin doesn't bounce back like maybe it would have in your 20s and 30s. So talking with your doctor about what some of the results are going to be when the drugs are successful and you're using them successfully, if you have significant weight loss, you can wind up with some other sorts of challenges.
You can. When I found out, I went from I was almost close to 200 pounds. I'm now about 153, 154 pounds. But I don't have any skin stretch or any flabby skin left over. So if you do it gradually and keep up with the exercise, it may be a little bit less.
Yeah.
So, any other thoughts? Any comments? Any questions? Anything in the chat? Anybody have questions for Dr. Walks and Dr. Lawson especially? Well, we're at the top of the hour. Let's go with our concluding remarks for the day, starting with Dr. Lawson.
You're on mute, Dr. Lawson. Dr. Lawson, can we get Dr. Lawson to unmute? That must be some South Texas sign language, Dr. Lawson. I don't know what you were trying to say. You're still on mute. There we
Yeah, I
go.
just want to emphasize before the early point I made that these pills are not, these agents are not magic bullets. Their work is temporary. If you stop using them, you gain the weight back. There's some exercises that they're very good for, especially Taekwondo and Kung Fu, because speed is important to you. Whereas, so one thing, they may reduce muscle mass, but they increase flexibility. So there's some other benefits from these agents. And above all, many of the complications before result of the fact we asked the question earlier, do you get people to stop eating? Some people early on when these drugs came out didn't stop eating. And as a result, they got all kinds of GI complications and everything else. Now, it's already stated that if you prepare people early, let them know what they're going to get into, and begin early to restrict the food intake, then you don't get some of these other GI complications.
Let me ask a medical question of our technician, Simon. For an older person, such as somebody who's 80 to 85 years old, what's the value of something like Tai Chi versus Taekwondo and those types of activities, Simon?
I mean, I couldn't really say 100% for sure. Aside from the longer you stay active, the longer you'll be able to stay active.
Amen.
Well, as a black belt in Taekwondo who's 80 years old, let me say that it is very, very useful, but don't get into active competition unless you have to go out and stick to kata.
Okay. You want to speak a minute about a 16-year-old Simon who's a champion?
Well, he's not exactly the champ yet, but my son has been competing this year, and I'm trying for Taekwondo, 2 first place finishes and the second place in Kumite. So
Right.
And how old is he? How tall is he?
17, and he's 6'4".
All right. Dr. Walks.
Yeah, I've been 17, but never 6'4", so I know about that. Congratulations, Simon. I think that is wonderful. And Dr. Lawson still being active and still understanding about the value of staying active. I think we just all have to do that.
Dr. Walks, I don't know karate, but I know crazy.
Yeah, I know you, Dr. Maxey, so I understand that. I've studied. There was a question about the effectiveness of Tai Chi versus Kung Fu. I've studied Tai Chi and I've studied Kung Fu, and I think that both have a great amount of utility, especially with the balance that's needed for both of them. We talked a little bit about balance and flexibility, and I think that especially when you see folks doing Tai Chi who've done it over a long period of time and do it very well, also the cognitive benefit of being able to concentrate at a level to learn some of the longer katas that that Dr. Lawson talked about with being a black belt in any of the martial arts. There is a lot of utility in continuing to use our bodies and our brains in ways that challenge us over time. So I would say that maybe one of the most important things that we heard today, that we talked about today, was the anecdote that Dr. Maxey gave about his slow weight loss over time from 200 to 150. And combine that with Dr. Lawson's comment about folks regaining weight when they stop taking these drugs, and especially when they stop moving around. Our bodies don't do well when we bounce from 210 to 160 back to 220 to 140. It is a very unhealthy thing for us to do. So I think that whatever we're going to do, we do it. We all want to be that 80-year-old black belt, and then we want to be that 90-year-old black belt. We want to continue to do the things that make sense in our lives that allow us to stay active. That's what I got.
Thank you very much. Dr. Nabors-Stephens.
Well, thank you, Dr. Maxey, for bringing a topic forward that people are being confronted all day long on TV with commercials addressing these drugs. One of the things I've been seeing that I am concerned about is the online access to these drugs that has become available. I don't know how much support there is and guidance in those kinds of arrangements. They are attractive because of the cost factor, which we didn't talk about at all, for these drugs. So I just want to end with you've heard very good reasons why you might want to consider using these drugs, but please, please use them in concert with your practitioner.
Thank you, Dr. Nabors-Stephens. Another point, just yesterday, I think the FDA approved a new GLP-1 drug that's a generic, so it'll be very cheap and it's oral. So they're going to be more, I guess, people able to get it, but again, with the points we raised, there has to be more control and consultation with your doctor, not just take a pill because it's cheap and works. But you have to do what you have to do along with the exercise, good nutrition, make sure you have weight loss with strength and nutrition with that, and not just take something because it's cheap. Also, I want to talk about next week on the 14th, we're going to be graced with a young lady who's a family practitioner and who is well trained from Boston as well as Northern California. She's going to speak about issues about women's health and the use of the term Black when you treat people. She has some opposition to that and thinks that people have more surgery for fibroids when they don't need it. They have more surgery for pregnancies when they don't need it. And she's going to join the name of Dr. Dua Hassan, and she's going to be our guest. And also, one of our other favorites is going to be with us in the coming weeks, Dr. Virginia King, having an expanded discussion about these infectious disease processes and also the vaccines. So thank you very much, and thanks everybody for joining us. Thank you, Simon. Everybody have a great Sunday. Have a great day.
Good day,
Bye.
everyone.